Clinical pharmacology, the object and purpose, pharmacodynamics and pharmacokinetics. Introduction to clinical pharmacology. The second half of 20th century saw a rapid increase in development of new medications, leading to a growing need for specialists in clinical pharmacology. Clinical pharmacology focuses on studying how drugs interact with the human body and aims to ensure their safety and effective use. In today's world, modern trends like personalized medicine and advanced clinical trials are transforming this field. How do you think personalized medicine can help treat common conditions like high blood pressure and diabetes? In high blood pressure management, personalized medicine uses pharmacogenomics to identify how a patient's genes affect their response to specific drugs. For example, genetic testing can reveal if patient has variations in the CYP2D6 gene, which is responsible for metabolizing beta blockers. If patient is a slow metabolizer, a lower dose or a different medication like an ACE inhibitor may be more effective and reduce side effects. Similarly, patients with variations in AGT or AGTR1 gene might respond better to angiotensin receptor blockers instead of ACE inhibitors. In diabetes, pharmacogenomics can determine how a patient responds to an oral medication like metformin. For instance, variations in the SLC22A1 gene can affect how metformin is transported in the body. Patients with certain genetic variants may require a higher dose or a switch to another drug like sulfonylureas or DPP-4 inhibitors to better control their blood sugar. Additionally, genetic testing can predict the risk of metformin-associated side effects such as gastrointestinal issues, helping with doctors make more informed treatment decisions. By using a patient's genetic profile, doctors can select the most effective medication from the start, avoiding the trial and error approach and improving the patient's overall treatment outcome. Statistics on drug side effects. In the United States, adverse drug reactions are a leading cause of hospitalizations. Recent data shows that 10 to 15% of hospitalized patients experience adverse drug reactions, costing over $136 billion annually. Modern pharmacovigilance systems monitor these reactions and help prevent serious consequences. The modern drug therapy. Drug therapy today can be as complex as potentially risky as surgery. With thousands of medications available, managing their interactions requires expertise. Managing multiple medications, especially in older patients or those with chronic diseases, is crucial for avoiding harmful interactions. For example, taking multiple medications like metformin for diabetes and lisinopril for hypertension can lead to several challenges. Drug interactions. For example, beta blockers, example atenolol, used for hypertension can mask symptoms of hypoglycemia, making it harder for diabetic patients to detect low sugar levels. Side effects overlap. Both metformin and ACE inhibitors like lisinopril can cause fatigue, making it hard to identify which drug is causing these symptoms. Adherence issues. Managing multiple drugs with different dosing schedules. Insulin injections plus amlodipine for blood pressure can confuse patients and reduce adherence, leading to poor control of both conditions. These challenges highlight the importance of careful management and monitoring when combining medications for conditions like diabetes and hypertension. Definition of clinical pharmacology. Clinical pharmacology is the science of studying drugs in humans with the primary goal of ensuring safe and effective use. Key aspects of modern clinical pharmacology include personalized treatment based on patient's genetic profile and genomic medicine. Practical example. Use an example of patient receiving a medication that is tailored to their genetic profile. For instance, how pharmacogenomics might influence a doctor's choice for blood thinner. Example scenario. A patient with atrial fibrillation is at risk of stroke and needs to be placed on anticoagulant to reduce the risk of clot formation. The doctor initially considers warfarin, but before starting therapy, the patient undergoes pharmacogenomic testing to determine their genetic profile. Pharmacogenomic considerations. CYP2C9 gene. This gene influences how the liver metabolizes warfarin. If the patient has a genetic variations in this gene, they might metabolize warfarin more slowly, increasing the risk of bleeding because the drug stays in their system longer at a higher concentration. Another gene that is called VKORC1. This gene is responsible for vitamin K recycling in the liver. The variants of this gene can determine how sensitive is the patient to the warfarin. Some patients might need a lower dose of warfarin due to increased sensitivity, or they might be resistant, requiring a higher dose. Doctor's decision. Based on genetic test results, patient is found to have a gene variation that makes them a slow metabolizer of warfarin. This would put the patient at a higher risk of bleeding complications if they were prescribed standard dose of warfarin. Additionally, the patient has a VKORC1 gene variant that makes them more sensitive to warfarin, meaning they would require even lower doses. Treatment selection. Instead of prescribing warfarin and attempting to make dosage adjustments based on the trial and error, doctor decides to prescribe apixaban, a direct oral anticoagulant that does not require monitoring or depending heavily on the patient's genes. Apixaban has a more predictable effect and is less influenced by genetic variations, making it a safer choice for this patient based on their genetic profile. Outcome. By using pharmacogenomic data, doctor avoids the risks associated with warfarin for the patient, potential bleeding due to slow metabolism, and chooses a more appropriate anticoagulant that does not require frequent monitoring or dose adjustments. This personalized approach leads to safer and more effective treatment for the patient. What are the fundamental objectives of clinical pharmacology? First, understanding the drug mechanisms, investigating how drugs interact with the body. Second, ensuring drug safety, monitoring drug to minimize adverse effects. Third, enhancing drug efficacy, tailoring treatments based on individual needs. Next, determining dosage, using therapeutic drug monitoring to find the right dose for each patient. There is a case study we can discuss as an example. Therapeutic drug monitoring in a patient with kidney disease. Patient, 65-year-old male, diagnosed with chronic kidney disease, stage 4, hypertension, and bacterial infection. That is pneumonia. Medication given for his infection is vancomycin for pneumonia, and vancomycin is an antibiotic often used to treat serious bacterial infections like pneumonia. It is primarily eliminated by kidneys, so in patients with impaired renal function, such as those with CKD, the drug can accumulate in the bloodstream, leading to toxicity. Example, nephrotoxicity or ototoxicity. Therapeutic drug monitoring is essential in patients with kidney disease to ensure the drug stays within the therapeutic range, maximizing efficacy while minimizing toxicity. The patient is admitted with pneumonia and started treatment with vancomycin due to its effectiveness against methicillin-resistant Staphylococcus aureus, MRSA, which is suspected based on clinical presentation. Laboratory findings: creatinine clearance is 20 milliliters per minute, indicative of severe kidney disease. Serum creatinine level is 3.8 milligram per deciliter. Estimated GFR is 25 milliliters per minute. Loading dose: vancomycin 1000 milligram IV initially. Based on kidney's function, the initial maintenance dose is set to 500 mg IV every 48 hours, given the patient's reduced kidney clearance. Therapeutic drug monitoring: since vancomycin is renally excreted, therapeutic drug monitoring is initiated to guide further dosing. Target through level: lowest concentration in the bloodstream before the next dose. For vancomycin, in treating pneumonia is typically 15 to 20 micrograms per milliliter. In day 3 of vancomycin dosage, vancomycin through level in the blood in the serum is 28 micrograms per milliliter. That is above therapeutic range. Clinical observation shows that patient has mild nausea and showing early signs of renal stress. Creatinine is stable, but GFR has slightly declined. Dose adjustments made: the elevated through level indicates that vancomycin is accumulating due to the patient's kidney disease. The dose is reduced to 500 mg IV every 72 hours instead of 48 hours to allow for more time between doses and avoid further accumulation. Day 6, second through level. Vancomycin through level is 18 micrograms per milliliter. That is within therapeutic range. Clinical observation shows that patient is improving clinically, reduction in pneumonia symptoms, and kidney function is stable. Since the patient's vancomycin level is now within the desired range, the current dosing schedule is maintained. Follow-up situation: patient continues treatment for the next 7 days with regular through monitoring every 3 days. His vancomycin levels remain within the therapeutic range, and his kidney function does not worsen. After completing the antibiotic course, the pneumonia resolves and vancomycin is discontinued. No signs of nephrotoxicity or ototoxicity are observed due to careful monitoring and dose adjustments. Conclusion: in this case, therapeutic drug monitoring, was crucial in adjusting the vancomycin dose to avoid toxicity while maintaining effective treatment. The patient's impaired kidney function required lower and less frequent dosing with regular monitoring to ensure drug levels maintained within the therapeutic range. What is the practical applications of clinical pharmacology? Clinical pharmacologists select the right medications, decides on dosages, monitor for side effects and interactions. This process is especially important when managing patients with chronic diseases who are on multiple medications. There is a sample case. In local practice, metformin is one of the most commonly prescribed medications for type 2 diabetes. A real-life example is managing the gastrointestinal side effects that many patients experience, such as nausea, diarrhea, and bloating, especially at higher doses. For instance, a 50-year-old patient started on metformin 500 mg twice daily for diabetes control, came back after a week complaining of severe diarrhea and abdominal discomfort. The approach was to reduce the dose to 500 mg once daily, initially to allow the body to adjust. Switching to metformin XR, that is extended release formulation, which is gentler on the stomach. Advising the patient to take medications with meals to minimize GI upset. This personalized approach helped manage the side effects while keeping the patient on the effective medication for diabetes management, highlighting the need for dose adjustments and formulation changes based on individual tolerance. Helsinki Declaration on Clinical Trials. The Helsinki Declaration emphasizes that patient safety must come first in clinical trials. Informed consent is essential, and patients should always understand the risks. Today, AI models and digital tools help ensure clinical trials are more effective and safer. When conducting clinical trials, several ethical considerations are crucial, especially in the local context. First, informed consent. Patients must fully understand the risks, benefits, and purpose of the trial before participating. This is especially important if literacy levels or understanding of medical research are limited in the region. Patient safety. Ensuring that participants are not exposed to unnecessary risks and that the benefits of trial outweigh the potential harms. This is critical, especially in healthcare systems with fewer resources for managing adverse events. Equal selections. Participants should be selected fairly, ensuring vulnerable populations, low income, less educated are not exploited, and all groups have access to the potential benefits of the trial. Another important part is data privacy. Protecting confidentiality of patient information is essential, ensuring that local regulations on data protection are followed. And another part we should take into consideration is cultural sensitivity. The trial design and patient communication should respect local customs, beliefs, and languages to foster trust and understanding between doctors and patients. By addressing these issues, clinical trials can be conducted ethically, ensuring patient safety and integrity within the local healthcare system. Phases of clinical trials. Phase 1. Testing safety and dosage on a small group. Phase 2. Evaluating effectiveness in a larger group. Phase 3. Confirming effectiveness and identifying side effects in a large population. Phase 4. Post-market surveillance using real-world evidence. Another case-based learning scenario. A new medication called Cardiac, designed to lower cholesterol, has passed clinical trials and is approved for public use. Initially, Cardiac shows great success in reducing cholesterol levels during controlled trials, but post-marketing surveillance reveals new insights. 6 months post-launch, real-world data from thousands of patients start showing reports of muscle pain and fatigue that were not prominent during clinical trials. Although these symptoms are mild, they affect a large number of patients, particularly those with pre-existing kidney conditions. 1 year later, patient experiences shared through social media registries, real-world data collection indicate a potential link between cardiacs and long-term kidney function decline in some patients. This prompts further investigation by regulatory authorities, which leads to updates in prescribing guidelines, recommending regular kidney function tests for patients using cardiacs. This scenario highlights the critical role that real-world data and patient-reported outcomes play in monitoring the long-term safety of new medications. While clinical trials provide valuable short-term data, real-world experiences can uncover side effects that only appear in broader populations or after extended use, ensuring ongoing drug safety and improvements in prescribing practices. Requirements for clinical trials. Clinical trials require a control group, randomization, and blinding to ensure accurate results. Newer tools like digital twin models, virtual patients are used to simulate clinical outcomes. Requirements for new drugs. New drugs must be more effective and safer than existing treatments, and they should have fewer side effects. Advances in biosimilar drugs and biologics are providing new options for treating chronic conditions like cancer and autoimmune diseases. Ensuring safe drug use. When prescribing a drug, doctors need to ask, first, what effect do we want to achieve? Second, is this the most appropriate drug for the patient? Third, what is the best method and dosage for administration? A sample case study about adjusting dosing for a patient with kidney disease. A sample patient is, let's take a Mr. Ali. Age is 70 years old. Medical history, chronic kidney disease stage 3, type 2 diabetes, hypertension. Current medications he's on are metformin 500 milligrams twice daily for diabetes, lisinopril 10 milligrams daily for hypertension, and gabapentin 300 milligrams 3 times a day for neuropathic pain. Clinical presentation. Mr. Ali presents with a worsening kidney function with his recent blood tests showing. Serum creatinine level is 2.2 milligrams per deciliter, increasing from 1.8 compared to previous lab results. Estimated GFR is 35 milliliter per minute, indicating stage 3 CKD. He complains of dizziness and excessive tiredness, which started about a week ago. Assessment. The doctor suspects the current dosing of his medications, particularly gabapentin, is too high for his level of kidney function. Gabapentin is primarily cleared by the kidneys, and in patients with reduced GFR, the drug can accumulate, leading to side effects such as dizziness, confusion, and sedation. Therapeutic drug monitoring and dosing adjustments. Doctor adjusts Mr. Ali's gabapentin dosage based on his GFR levels. Gabapentin is reduced to 300 mg once daily instead of 3 times daily to prevent toxicity. Additionally, doctor reviews the use of metformin because it is contraindicated in advanced kidney disease due to its risk of lactic acidosis. Since Mr. Ali's eGFR is close to the threshold for discontinuing metformin, the dose is reduced to 500 mg once daily with close monitoring of kidney function. Follow-up. After 2 weeks, Mr. Ali reports that his dizziness and fatigue have improved significantly. His follow-up lab results show stable kidney function, GFR remaining at 35 ml per minute, and his blood sugar remains under control with the adjusted metformin dosage. To conclude, in this case, therapeutic drug monitoring and adjusting doses based on kidney function were essential to prevent gabapentin toxicity and minimize risks associated with metformin. This highlights the importance of drug adjustments in patients with CKD to balance efficacy and safety. This concludes the Fundamentals of Clinical Pharmacology lecture. See you next time.